Good afternoon, everybody. I am going to introduce Dr. Kainth, who, as many of you know, joined us from NYP Queens in 2019 and has been a valuable member of our department ever since. And he's going to talk to us about the highly important subject of resistant hypertension.
Thank you for the introduction, Dr. Kapner. So good morning, everyone, or good afternoon. My name is Mandeep Kainth. I'm one of the cardiologists here at Montefiore, and today we'll be talking about resistant hypertension. And keep in mind that resistant is in quotation marks, and that's for a reason. So objectives for today are to review and compare past and current standards for treating hypertension, to compare and differentiate uncontrolled, refractory, resistant, pseudo-resistant, and secondary hypertension, to review the prevalence of resistant hypertension, the pharmacological treatment, as well as roles for hypertension specialists. So why do we care about hypertension? And this has to go with cardiovascular disease in general. So cardiovascular disease, including coronary heart disease, stroke, heart failure, remain the leading cause of morbidity and mortality. And hypertension is a major risk factor for cardiovascular disease. And more cardiovascular disease events in the US have been attributed to hypertension than any other modifiable risk factor. Antihypertensive medication use and controlling blood pressure levels reduce the risk of cardiovascular disease and all-cause mortality among adults with hypertension. The figure here shows that nearly 1 out of 2 adults in the US has hypertension. That's 116 million. Approximately 1 in 5 adults with hypertension in the US are recommended lifestyle modifications only. Most adults with hypertension in the US are recommended prescription medication with lifestyle modifications. And most adults with hypertension in the US do not have their hypertension under control. This is talking about 92 million people. Many adults in the United States who are already treated with hypertension medication may need to have their current medication dosages increased or to be prescribed additional medications to achieve blood pressure control. And many adults in the United States for whom hypertension medication is recommended are untreated and may need both a prescription and to start talking. So how have we been doing in the past 20 years? So the NHANES study, which is a National Health and Nutritional Examination Survey, defined hypertension as systolic blood pressure of 140 or higher and diastolic pressure of 90 or higher and antihypertensive use. They looked at controlled blood pressure, which is defined as systolic blood pressure lower than 140 and diastolic pressure lower than 90. Treatment was defined by self-reported antihypertensive use. And in a series of cross-sectional surveys, weighted to be representative of the US population, you can see that the prevalence of controlled blood pressure has increased steadily between 1999 to 2008. Between 2007 and 2014, the control did not change. And then from 2013 onwards, you see that the proportion of the population that has blood pressure control has been decreasing. It's important to note that the prevalence of hypertension and uncontrolled blood pressure status is disproportionately higher in some minority and underserved groups. So this is a dizzying time for hypertension management, especially since in the past couple of years, our guidelines have changed from 2014 with JNC8 to the new guidelines in 2017 with ACC and AHA to the European guidelines published in 2018. They all set various different blood pressure goals, which can get confusing to the clinician and for the patients. So let's compare the most recent guidelines that we have, which are the American Society of American College of Cardiology, as well as the European Society of Cardiology. And it's worth noting that both guidelines agree that in patients at high cardiovascular risk, the goal for blood pressure is less than 130/80. The European guidelines, however, mandate that everyone achieve a goal of less than 140/90 initially, and then they discuss the risks and benefits of reaching a lower goal, as they say that this approach should be individualized. The ACC/AHA guidelines, on the other hand, argue that a focus on calculating the absolute risk to guide the prescription of pharmacological therapy has yielded mixed results historically, and that recommending a universal blood pressure goal simplifies the decision regarding therapy. Essentially, changing the blood pressure thresholds previously used to define pre-hypertension eliminate this term and mandates a more aggressive therapy as well as assessment of ASCVD risk. However, what's consistent in both guidelines is that patients at high cardiovascular risk need more aggressive lowering of blood pressure to levels less than 130/80. The ESC guidelines ease into this gradually by stating that all persons' blood pressure should be less than 140/90, followed by a discussion with individual patients about their CV risk and the benefit of further lowering that to 130/80. So, what is resistant hypertension? We know that uncontrolled hypertension is over 140/90 or 130/80 in people that have elevated cardiovascular risk. So what is this term resistant hypertension? And resistant hypertension is defined as blood pressure that remains above goal in spite of concurrent use of 3 antihypertensive agents of different classes. And ideally, one of those 3 agents should be a diuretic, and all of these agents should be prescribed at optimal dose amounts. Although it's arbitrary in regard to the number of medications required, resistant hypertension is thus defined in order to identify patients who are at high risk of having reversible causes of hypertension, and or patients who, because of persistently high blood pressure levels, may benefit from special diagnostic and therapeutic conditions. Controlled resistant hypertension includes individuals at goal blood pressure, but taking 4 or more medications. And there is a subset of resistant hypertension that has been termed refractory hypertension. And refractory hypertension refers to people who have a greater blood pressure than goal, despite taking 5 or more medications, including a mineralocorticoid receptor antagonist and clothalidone. So what is the prevalence of resistant hypertension? And unfortunately, the true prevalence of resistant hypertension is unknown. To accurately determine the prevalence of resistant hypertension, we would need to do a forced titration study of a large, diverse, hypertensive cohort. And to this day, no study like that exists. However, there do exist a number of well-designed clinical trials from which prevalence rates of resistant hypertension can be estimated. Taken together, these studies suggest that pseudo-resistant hypertension, due to non-adherence or white coat hypertension, likely make up half of all of uncontrolled resistant hypertension individuals. Therefore, the prevalence of true resistant hypertension would be estimated at 5% and 4% amongst treated and all hypertensive patients, respectively. This small group of true resistant individuals who stand to gain the most from early identification and aggressive treatment is expected to shrink over time. With concentrated efforts on improving blood pressure control, assisted with dissemination of strategies to simplify and optimize multiple medication regimens, blood pressure control rates will likely continue to rise. So what is our approach, or what should be an approach to a patient with resistant hypertension? Initially, we should evaluate the blood pressure and exclude pseudo-resistance. We should then identify and reverse contributing lifestyle factors. discontinue or reduce interfering substances, consider secondary causes of resistant hypertension, ensure pharmacologic treatment, and if all else fails, refer to a hypertension specialist. Now, you may think that a discussion on how to take blood pressure should not be necessary in a talk like this. However, you'll be surprised at how much of this is actually not done correctly. This is important because you'll be making medical decisions based off these readings. And if inaccurate, your entire medical decision is now inaccurate. So what are the steps in order to do an in-office blood pressure measurement? The first step is proper patient placement. You should have the patient relax, sitting in a chair with the feet on the floor and back supported for more than 5 minutes. The patient should have avoided caffeine, exercise, and smoking for at least 30 minutes before this measurement. Ensure that the patient has emptied his or her bladder. Neither the patient nor the observer should be talking during this rest period or during the measurement. They should remove all clothing that's covering the location of the cuff, and the measurements should be made while the patient is sitting or lying, and the patient sitting or lying on an examining table do not fulfill these criteria. Step number 2 is to make sure you use proper technique for blood pressure measurement. This includes a validated blood pressure measurement device that's been calibrated and checked periodically, including proper supporting of the patient's arm, such as resting on a desk, positioning the cuff correctly in the middle of the patient's upper arm at the level of the right atrium, and the use of the correct cuff size such that the bladder encircles 80% of the arm. The third step is to take proper blood pressure measurements needed for diagnosis and treatment. At the first initial visit, record blood pressure in both arms and use the arm that gives the higher reading for subsequent readings. Blood pressure readings that are different by more than 10 millimeters of mercury should prompt an evaluation for vascular abnormalities, some of which could be causes for secondary hypertension. Readings should be separate by at least 1 to 2 minutes. Step 4 is to document all readings. Step 5 is to average the readings, and an average of greater than or equal to 2 readings should be obtained on greater than or equal to 2 occasions to estimate the individual's levels of blood pressure. And step 6 is to provide the blood pressure reading to a patient and verbally and in writing. First, it's critical to establish the diagnosis of resistant hypertension, as elevated blood pressure in the clinic does not necessarily define resistant hypertension. Pseudo-resistant hypertension is an elevated office blood pressure that is not due to antihypertensive medication treatment failure. And pseudo-resistant hypertension can be caused by erroneous blood pressure measurements, white coat hypertension, or medication non-adherence. It's also important to note that inadequate treatment should be considered a form of pseudo-resistance as well. The diagnosis and management of hypertension have been based primarily on the measurement of blood pressure in the office. However, blood pressure may differ considerably when measured in the office and when measured outside the office. White coat hypertension is defined as having high office blood pressure measurements and not having high out-of-office blood pressure measurements. Masked hypertension is defined as not having high office blood pressure measurements and having high out-of-office blood pressure measurements. These terms, white coat hypertension and masked hypertension, only apply to individuals not taking antihypertensive medications. For individuals that are on antihypertensive medications, the terms white coat effect and masked uncontrolled hypertension are used. Now, recent evidence suggests that compared with sustained normotension, white coat hypertension is associated with either no increased or moderately increased cardiovascular events or mortality. white coat hypertension is associated with less risk of cardiovascular events and mortality compared with hypertension. And prior studies show that compared with sustained normotension, white coat effect is not associated with an increased risk of cardiovascular events, whereas masked hypertension and masked uncontrolled hypertension are associated with an increased risk of cardiovascular events and mortalities. These blood pressure phenotypes can be identified only by both office and out of office blood pressure monitoring. And discordant in office and out of office blood pressure readings are common. Because of this, out of office readings and self-monitoring of blood pressure is class 1A recommendation in the 2017 American Blood Pressure Guidelines. This really highlights the role of out of office blood pressure monitoring, which really should be complementary to office blood pressure monitoring. Out of office blood pressure monitoring is present in two forms: ambulatory blood pressure monitoring and home blood pressure monitoring. These two methods, for several reasons, including timing, tolerability, and availability, are not entirely interchangeable. Ambulatory blood pressure monitoring is a fully automated technique in which the blood pressure is recorded over an extended period of time, typically 24 hours. How they work is that they're fully automatic with a pump to inflate and deflate the blood pressure cuff at set intervals. The standard is every 20 minutes while awake and every hour while sleeping. You can set these monitors for what you feel is good for your patients. Typically, in a 24-hour period, you'll have a recording of somewhere between 50 to 100 readings. All of these readings are stored in memory and then uploaded into a computer or ambulatory blood pressure analysis system. This is an example of an ambulatory blood pressure report. Some key findings here are the awake period summary, the asleep period summary, the hourly average, the lowest blood pressure, the highest blood pressure, as well as if there's any nighttime dipping when the patient goes to sleep. We'll talk more about this later. Self-measured blood pressure monitoring at home is a measurement of blood pressure by an individual outside of an office at his or her home or at a pharmacy, kiosk, anything. There's moderate agreement between blood pressure on ambulatory monitoring and self-measured monitoring, suggesting that these measures may not be interchangeable. It's important to recognize that there's strong evidence that self-measured blood pressure monitoring adds value over and above office blood pressure measurement for predicting end organ damage and cardiovascular outcomes. There are several systematic reviews and meta-analysis that have concluded that self-measured blood pressure is superior to office blood pressure in regards to the association with echocardiographic left ventricular mass index. Compared with office blood pressure, self-measured blood pressure is also a better predictor of urinary albumin to creatinine ratio, proteinuria, and silent cardiovascular disease. Few studies have compared the association between self-measured blood pressure and cardiovascular events versus the association between blood pressure on ABPM and cardiovascular events. And there was a recent systematic review that indicated that there's a lack of any strong evidence demonstrating superiority of one over the other. So let's talk about blood pressure devices on the market and how we can choose one for monitoring, since we know there are many out there. Lots of these devices will claim FDA approval. However, that's not the same as being validated for use as intended. The AMA convened with experts and relevant technical and clinical practice expertise to develop a set of criteria known as the VDL criteria, which aid in determining which automated blood pressure measurements devices in the US have been validated for clinical accuracy. The VDL criteria were refined and finalized with input from key stakeholders, including clinicians, healthcare organizations, blood pressure device manufacturers, and the FDA. There's a website called validatebp.org where this information is readily available. It's a site where you have information about the device, the different models, the sizes, the validation protocols that are used, and it's really readily accessible in a very centralized website. These are just some examples of what is available on there. I urge you to go there and check it out yourself. Poor adherence to antihypertensive therapy is a major cause of lack of blood pressure control. Retrospective analyses indicate that approximately 40% of patients with newly diagnosed hypertension will discontinue their antihypertensive medications during the first year of treatment. During the first year of treatment, during 5 to 10 years of follow-up, less than 40% of patients may persist with their prescribed antihypertensive treatment. While poor adherence is common at the primary care level, it may be less common among patients who are seen by specialists. In a retrospective analysis at a hypertension specialty clinic, it was estimated that poor adherence was a significant contributing factor to the lack of blood pressure control in only 16% of evaluated patients. Lack of blood pressure control is distinct from treatment resistance. For an antihypertensive regimen to have failed, it has to have been taken correctly. And this distinction is clinically important as patients with poorly controlled hypertension secondary to lack of adherence need not be subjected to the evaluations and continued manipulations in treatment regimens that are undertaken for patients with true resistant hypertension. Ultimately, adherence in a clinical setting can only be known by a patient self-report. Patients should be specifically asked in a non-judgmental fashion of how successful they are in taking all of their prescribed doses, including discussion of adverse effects, out-of-pocket costs, and dosing inconveniences. So what are some methods to improve adherence? One is to establish a goal with the patient. Another one is to maintain contact, including frequent follow-up. Another one is to keep care inexpensive and simple, and this includes fewest daily doses of drugs, consideration of single pill combinations, tailoring the medications to the routine, pill boxes, packaging, etc., and prescribing according to pharmacological principles. So now that we have done our initial blood pressure evaluation and hopefully excluded pseudo-resistance, the next step is to identify and reverse contributing lifestyle factors. Perhaps more overlooked in specialty clinics than primary care offices is a significant need for lifestyle modification in the treatment of resistant hypertension. As noted in the 2017 American Blood Pressure Guidelines, lifestyle is a key component to controlling blood pressure, and high-quality data show that adherence to appropriate lifestyle modification reduces blood pressure significantly. The impact of dietary patterns in lowering blood pressure is well established. The highest quality evidence emanates from the 1997 DASH trial. Undertaking a diet with fruits and vegetables, with low-fat dairy and reduced fat cholesterol reduced blood pressure significantly compared with trial participants undertaking a control or average diet. The effect was most pronounced in patients with hypertension, where office blood pressure was reduced by as much as 11 points systolic. Because the study was published almost 25 years ago, clinicians often forget that the original DASH diet was not a low-sodium diet. Trial participants consumed on average more than 3 grams of sodium daily. To study the combined effects of a DASH diet pattern as well as low sodium intake, a follow-up study was undertaken and published in 2001. And unsurprisingly, lowering daily sodium intake decreased blood pressure beyond the declines seen in the original DASH diet by an additional 3 points systolic. Undertaking both low sodium and DASH dietary patterns is beneficial in lowering blood pressure, particularly at higher levels of both systolic and diastolic blood pressure. Efforts should clearly be made to provide patients with referrals to registered dietitians and nutrition programs to optimize their dietary patterns. However, in practice, focusing initially on a low sodium intervention is simpler for patients to comprehend and can be fully explained to the patients during typical clinic visits by a physician. Although there are varying maximum levels of daily sodium intake recommended in patients with hypertension, the authors of this clinical guideline document favored reducing daily sodium intake to at least 2.3 grams and less than 1,500 grams daily if sustainable. Another key lifestyle factor is obesity. Obesity is associated with more severe hypertension, a need for increased number of antihypertensive medications, and an increased likelihood of never achieving blood pressure control. The mechanisms of obesity-induced hypertension are complex and not fully elucidated, but include impaired sodium excretion, increased sympathetic nervous system activity, and activation of the renin-angiotensin-aldosterone system. Heavy alcohol take is associated with both an increased risk of hypertension as well as treatment-resistant hypertension. And prospective studies showed that cessation of heavy alcohol ingestion by a small group of patients reduced 24-hour ambulatory blood pressure by as high as 7 millimeters of mercury. The impact of sodium, reducing dietary sodium in resistant hypertension can be profound and is clearly shown in a study of 12 patients with resistant hypertension who underwent a randomized crossover evaluation of high sodium and low sodium diets for 7 days each, with a 2-week washout period in between. So they had 1 week of low sodium diet, whereas the other arm had 1 week of high sodium diet, 2-week washout, and then they flip roles. 24-hour blood pressure monitoring was performed after each level of sodium consumption, and the mean change between high and low sodium intake was as high as a difference of 20 points systolic and 9 points diastolic. And notice here that the effect of sodium restriction is intensified in patients with resistant hypertension, with a systolic blood pressure reduction by as high as 22 points. Our next step is to evaluate and discontinue or reduce interfering substances. Numerous substances, including prescription medications, over-the-counter medications, herbals, food substances, may affect blood pressure. And changes in blood pressure that occur because of drugs and other agents have been associated with development of hypertension, worsening control in the patient who already has hypertension, or attenuation of the blood pressure lowering effect of antihypertensive therapy. A change in blood pressure may also result from drug-drug or drug-food interactions. And in the clinical assessment of hypertension, a careful history should be taken with regard to substances that may impair blood pressure control, with close attention paid to not only prescription medications, but also over-the-counter substances, illicit drugs, and herbal products. When feasible, drugs associated with increased blood pressure should be reduced or discontinued, and alternative agents should be used. Several classes of pharmacologic agents can increase blood pressure. Given their widespread use, NSAIDs, aspirin, acetaminophen are probably the most common offending agents in terms of worsening blood pressure. Other medication classes that may worsen blood pressure control include sympathomimetic compounds, such as decongestants, certain diet pills, amphetamine-like stimulants, modafinil, and oral contraceptives or glucocorticoids. This list here is a list that's in the ACC guidelines for hypertension. It's completely not all-inclusive. Secondary causes of hypertension are common in patients with resistant hypertension, although the overall prevalence is unknown. This is a summary to guide us on how to approach it so that if we have new onset hypertension or uncontrolled hypertension in adults, we look for certain pre-specified conditions from our initial evaluation. We look to see, is there drug-resistant or drug-induced hypertension? Was there an abrupt onset of hypertension? Is this a new onset hypertension at a young age? Is there an exacerbation of a previously controlled hypertension? Is there disproportionate amount of target organ damage for the degree of hypertension? Is there an accelerated or malignant type of hypertension? Is there onset of diastolic hypertension in older adults, where we might typically see more of a systolic hypertension? Or is there unprovoked or unexplained excessive hypokalemia? In these scenarios, we might decide it's time to screen for secondary hypertension, and this is a class 1 indication. The likelihood of a readily definable secondary cause of hypertension is greater in older patients because of a greater prevalence of sleep apnea and renal parenchymal disease, renal artery stenosis, and possibly primary hyperaldosteronism. Uncommon secondary causes of hypertension include pheochromocytoma, Cushing syndrome, hyperparathyroidism, aortic coarctation, and intracranial tumors. I'm going to take a few minutes to talk about primary hyperaldosteronism. It's one of the most frequent disorders, occurring in up to 5 to 10% of patients with hypertension, and as high as 20% of patients with resistant hypertension. The toxic tissue effect of aldosterone induces greater target organ damage in primary hyperaldosteronism than in primary hypertension. Patients with primary aldosteronism have a 3.7-fold increase in heart failure, 4-fold increase in stroke, 6-fold increase in MI, and a 12-fold increase in atrial fibrillation. They also suffer from increased left ventricular hypertrophy and diastolic dysfunction, increased stiffness of large arteries, widespread tissue fibrosis, and increased kidney damage as compared to patients with primary hypertension. Because of the deleterious effects of aldosterone overproduction are often reversible with unilateral laparoscopic adrenalectomy or treatment with mineralocorticoid receptor antagonists. Screening of patients with hypertension is at increased risk of primary aldosteronism is beneficial. The aldosterone to renin activity ratio is currently the most accurate and reliable means of screening for primary aldosteronism. If unilateral aldosterone production is documented on adrenal venous sampling, the patient's referred for unilateral laparoscopic adrenalectomy, which improves blood pressure in virtually 100% of patients and results in a complete cure of hypertension in about 50%. Both adrenalectomy and medical therapy are effective in lowering blood pressure and reversing LVH. Treating primary aldosteronism either by a mineralocorticoid receptor antagonist or adrenalectomy, if indicated, resolves hypokalemia, lowers blood pressure, reduces the number of antihypertensive medications required, and improves parameters of impaired cardiac and kidney function. Another big topic is obstructive sleep apnea. Obstructive sleep apnea is a common condition characterized by recurrent collapse of upper airways during sleep, inducing intermittent episodes of apnea, hypopnea, hypoxemia, and sleep disruption. Obstructive sleep apnea is a risk factor for several cardiovascular diseases, including hypertension, coronary and cerebral vascular disease, heart failure, and AFib. Observational studies have shown that the presence of obstructive sleep apnea is associated with increased risk of incident hypertension. OSA is highly prevalent in adults with resistant hypertension, up to more than 80%, and it has been hypothesized that treatment with CPAP may have more pronounced effects on blood pressure reduction in resistant hypertension. Resistant hypertension is almost always multifactorial in etiology. Treatment of resistant hypertension involves improving medication adherence, improving detection and correction of secondary hypertension, and addressing other patient characteristics. Treatment is predicated on identification and reversal of lifestyle factors contributing to treatment resistance, accurate diagnosis and appropriate treatment of secondary causes of hypertension, and the use of effective multi-drug regimens. Lifestyle changes, including weight loss, regular exercise, ingestion of high fiber, low fat, low salt, and moderation of alcohol intake should be encouraged where appropriate. Potentially interfering substances should be withdrawn or down titrated as clinically allowable, and sleep apnea should be treated if present. So this is just an overview of the principles of treatment. First line is ACE inhibitors or ARBs. You should optimize volume status, optimize renin-angiotensin receptor blockade, chronotherapy, using beta blockers as number 5. And if you're unable to tolerate either clonidine or as a last resort, hydralazine or minoxidil. So treatment of resistant hypertension involves improving medication adherence, detection, and correction of secondary hypertension, and addressing other patient characteristics. Pharmacological therapy with combinations of medications with complementary mechanisms of action provide an empirical approach that enhance blood pressure control while mitigating untoward effects of potent vasodilators. For this reason, calcium channel blockers, inhibitors of renin-angiotensin system, and clothalidone comprise a common 3-drug regimen. Notice here that beta blockers are not considered first-line therapy. Chlorthalidone is a much more effective than hydrochlorothiazide, about twice as potent as HCTZ at 25 milligrams a day, has a much longer duration of action, and is effective at a lower GFR. This is from a crossover study comparing chlorthalidone to hydrochlorothiazide. 24-hour ambulatory blood pressure, daytime blood pressure, and nighttime blood pressure were all better with chlorthalidone, and the biggest difference was with overnight blood pressure, which resulted in doubling the reduction of systolic blood pressure with clothalidone. This is probably because it's longer duration of action, and it's critical because of the importance of non-dipping in patients with resistant hypertension and CKD. Optimizing renin-angiotensin receptor blockade. ACEs and ARBs have a synergistic effect with diuretics. Use of long-acting ACE and long-acting ARBs are better. Losartan actually has less blood pressure and lowering effect compared with other angiotensin receptor blockers, and it's not long-acting. There's considerable evidence that indicates that addition of spironolactone to multi-drug regimens provides substantial blood pressure reduction when compared with placebo. There's substantial data also demonstrates the advantages of spironolactone as compared with other active drugs. In particular, the recent Pathway 2 randomized controlled trial demonstrated the superiority of spironolactone over alpha and beta blockers. In a double-blind, placebo-controlled crossover trial of patients with resistant hypertension, spironolactone was superior to doxazosin and bisoprolol as an add-on therapy. This was particularly true for patients with low renin that suggests that those patients were volume expanded. Eplerenone is a selective MRA that does not have the non-selective binding to steroid receptors that spironolactone does. Therefore, it does not cause sexual side effects such as gynecomastia, breast tenderness, and low libido, but may be less efficacious and cost more. In a cohort of 46 patients who had spironolactone or eplerenone added to a stable antihypertensive regimen, including maximally dosed renin-angiotensin receptor blockade and appropriately dosed diuretic, a baseline GFR of less than 45 and a baseline potassium of more than 4.5 were the strongest predictors of hyperkalemia. And in those patients, spironolactone should be avoided. Chronotherapy. So the dosing of multi-drug regimens, occasionally including nighttime dosing, may be best optimized by hypertension specialists. There are many physiological functions that are under control by our circadian rhythm. This includes the urinary excretion of sodium. Abnormal circadian rhythm for renal sodium reabsorption is a major factor that leads to the loss of nocturnal dipping that we see in patients that have resistant hypertension. And we hypothesize that the blood pressure increases at night to promote sodium excretion. Chronotherapy refers to bedtime dosing of medications, and this can help restore normal nighttime dipping patterns. It can improve nocturnal and 24-hour ambulatory blood pressure. It can decrease proteinuria and may be associated with a decreased risk of cardiovascular morbidity and mortality, particularly in CKD patients. There's also clinical trial evidence that the addition of hydralazine or minoxidil is effective in achieving blood pressure control in patients resistant to usual combination therapy. Keep in mind that beta blockers, clonidine, hydralazine, these are steps 5, 6, and 7. You should really focus on your first line agents and then add spironolactone if necessary. So what if we were able to achieve perfect care? So we use this recent computer simulations to determine the practical clinical-based strategies for the management of patients with uncontrolled blood pressure that would achieve 80% blood pressure control by the year 2022. So what this model did was it looked to see individual effects on potential outcomes and potential control of blood pressure. If we independently improved patient adherence to 100% and nothing else, we would increase our blood pressure control rate from 54 to 57%, which is not too dramatic. If we independently reduced the return visit interval to 1 week, so just had patients come back every single week, we would increase the blood pressure control rate to 67%. And if we independently increase the probability that a provider intensifies the blood pressure medications to more than 62%, we can increase the blood pressure control rate to more than 80%. Now, this seems like too intense to do. So what if we do practical changes? So if we implement practical changes to hypertension management, such as 70% medication adherence, or greater than 30% of treatment intensification, and having a follow-up visit within 4 weeks of an uncontrolled hypertension office blood pressure, we can still reach our goal of 80% within the next 4 years. If adequate blood pressure control cannot be achieved through the strategies outlined above, consider a referral to hypertension specialists for further evaluation and consideration for enrollment in randomized controlled trials of novel therapies, such as renal nerve sympathetic ablation or other therapies under investigation. Outcomes of trials do not always translate into real-world practice settings, as results are not driven by protocols and study coordinators hounding patients. Hence, there's no substitute for clinical judgment and discussion of risk and the suggested approach with an individual patient. The primary issue is to how to properly achieve the high quality required to assess blood pressure, to counsel and educate patients, to get patients involved in their care in the short time allowed for by payers. One effective way to do so, given the current constraints of billing and time, is to request additional time on the patient's part and use of the existing workforce. This is just one of the proposed algorithms that maximizes the time and labor while minimizing increased cost to a practice. As you can see, if you spend 7 to 8 minutes checking the blood pressure according to the guidelines, you take another 3 to 4 minutes to review the blood pressure medications and update the list appropriately. Take another 7 to 10 minutes to discuss and review the lifestyle. 1 minute to punch in all these numbers in the ASCVD app. That's taking 23 to 28 minutes just on that for one physician visit, which seems like it might be too much to do in a primary care setting. And for this reason, referral to a hypertension specialist might be beneficial. In summary, cardiovascular diseases, including coronary heart disease, stroke, heart failure, remain the leading cause of morbidity and mortality. And patients with resistant hypertension may benefit from special diagnostic and therapeutic considerations. Thank you.
Hi, Mandeep. It was a very comprehensive talk. Thank you. So I apologize for getting on late. I was actually seeing patients in MAP, including a patient who came for follow-up for hypertension. So I was thinking about what you were up to. So I'm just going to obviously anybody can feel free to send a question through into the chat. Perfect. So there's the activity code 17LATH. Mandeep, if you could talk for a second about, I know that you have been pursuing on your own the possibility of us having access to home blood pressure monitors, ambulatory blood pressure monitors up here at Montefiore. Could you just, if you're able to, sort of comment on the status of that program for us?
Yes, definitely. So currently, the ambulatory blood pressure monitoring program is done through nephrology. Dr. Molly Fisher is the one that does them. We are in the process of actually getting that done through cardiology as well. That's something that's in the works, and I can keep you guys updated when that'll be done for us. I will be the person that does that. So that's just a matter of acquiring the monitor and getting it for us. In terms of home blood pressure monitoring, there's some clinics that are out in, I want to say either Nyack or in some of the satellite sites that actually already are enrolling patients in remote patient monitoring systems, which is also a very beneficial, very helpful way to track blood pressure control by no other work by the provider themselves. Essentially, patients take home a connected blood pressure monitoring machine, which gets remotely uploaded, run by a third party who then generates reports and sends them to us. That's something that we were talking about getting to the main sites over here. I'm not exactly sure where we are in that process, but it's something that's kind of upcoming for us.
Cool. Obviously, that'll be a big boon for us, and I think a big help for the optimization. So there's a question from our audience member. Oopsie, hold on 1 second. Let me just disappear. When do you test for primary aldosteronism? It's not so infrequent condition, and the best for practical first test in your thoughts.
Oh yes. So if I just go back to my slides.
Billy, can you help him with that, or you know how to do that?
Am I still sharing my screen? Or?
I'm sorry, what happened?
Can you just help Dr. Kainth to get his slides back. He just wanted to go back to one of his slides.
I can share the screen. That's not a problem. Okay, are you guys seeing my screen?
Perfect, yes.
Okay, so before I talk about that, I'm just gonna go back just a little bit. So this is a summary slide. So these conditions, if you are having new onset uncontrolled hypertension in adults, if you meet any of these conditions, drug-resistant or induced hypertension, abrupt onset, onset at a young age, exacerbation of previously controlled hypertension, disproportionate target organ damage for degree of hypertension, accelerated or malignant hypertension, or onset of diastolic hypertension in an older adult, or unprovoked or excessive hypokalemia. Mostly with hyperaldosteronism, it's the hypokalemia that should kind of clue you in. But if any of these other conditions are met, it's class 1 to start screening for secondary causes of hypertension. And let me just fast forward to hyperaldosteronism. The initial test is the plasma aldosterone to renin ratio. And that's the best initial test. And then you have confirmatory tests afterwards, either with sodium loading, and then they can do CT, followed by adrenal vein sampling. But the initial test should be the plasma aldosterone to renin ratio.
Perfect. And I apologize, I may have missed it because I had to step out for one quick second while you were talking about the therapeutic options. Could you comment for a second on where your survey of the literature takes us now with renal artery denervation therapy for resistant hypertension?
So right now, it's still in clinical trials. It hasn't actually been, there's no, it hasn't made its way into the guidelines yet, and there's no solid indication for it. So the only way to really go through this is to refer to a hypertension specialist that is serving in a community that currently offer that, which we are not one of yet.
Okay. Okay, so if there are no further questions, thank you, Mandeep, for a very comprehensive review. For the fellows who were listening, a lot of the details that Mandeep was going through actually appear at the core of a lot of questions on the boards regarding hypertension and on the recertification board. So this is highly relevant for not only in our day-to-day practice, but also in our certification process. So thank you, Mandeep. And Millie, thank you, and we'll see you again next week.
Thank you, everyone.